Okay, this review, we're going to focus on what you need to know for the final exam in pulmonary function. So I'm looking at the review sheet that I posted in D2L under final exam review. And the first thing it mentions is review lung volumes and capacities. So for lung volumes, you're looking at the 4 different lung volumes: your residual volume, your expiratory reserve volume, your tidal volume, and your inspiratory reserve volume. And then for capacities, you're looking at your inspiratory capacity, your functional residual capacity. So FRC consists of residual volume and expiratory reserve volume. Another capacity is the vital capacity, and that's all the air that can be exhaled from a maximum inspiration. So when you're exhaling your inspiratory reserve volume, your tidal volume, and your expiratory reserve volume. And then, of course, there's total lung capacity. As far as restrictive diseases and obstructive diseases, a restrictive lung disease causes lung volumes to be smaller. And there's a lot of different restrictive diseases, but anything that causes lung volumes to be smaller will be considered restrictive. Some of the examples that we went through in our notes were fibrotic lung diseases, because when there's fibrotic tissue in the interstitial space, it's harder to take in a breath of air, so lung volumes become smaller. We talked about pulmonary edema affecting lung volumes, pleural effusions affect lung volumes. So anything having to do with lung volumes, atelectasis, it's considered restrictive disease. Obstructive diseases, we use the mnemonic CBABE to remind us of the different types of obstructive diseases. So cystic fibrosis, bronchitis, asthma, bronchiectasis, and emphysema. And we came up with another one. We realized that when there's a tumor growing into the airway, and it's not completely blocking the airway, that becomes an obstruction also. So there are several test questions, and you have to identify whether it's restrictive or obstructive. Number 3, it says review definitions of each test and each measured parameter is outlined in the class PowerPoint notes. And that's when we talked about FEV. FEV1 is the forced expiratory volume after 1 second. FVC is the complete forced vital capacity. When you make the FEV1 over FVC a fraction, it becomes a percent, so FEV1%. And there are other ones that show up on the pulmonary function exam. So there are values that you're not required to know. So we didn't go through them when we looked at case studies, and you don't need to know them on the final exam. Like it looks at FEV 0.5, FEV 2%, FEV 3%. So we can ignore all those numbers and just focus on FVC, FEV1, and then FEV 1%. What else do we go through? We went through wow, try to recall everything from the semester without my notes in front of me. Went through, I don't know if my list is going to be complete, so you're going to have to use your PowerPoint notes to go through all of the different parameters that we look at on a PFT report. I know MVV, helium dilution, diffusion capacity, looking at what airway resistance, compliance from the body box. So I don't know if I'm giving you a complete listing, but review all of the different testing in your PowerPoint. Number 4, it says review PFT reports to determine obstructive versus restrictive versus normal lung disease and whether a bronchodilator is indicated. If a bronchodilator is indicated, evaluate the changes in FEV1 and FVC to see if the bronchodilator improved the airway obstruction. All right, so looking at obstructive versus restrictive. For obstructive lung disease, we're looking at the FEV 1%. If it's 80% and more, it's normal. Less than 80% is considered obstructive lung disease. And then there's different levels of airway obstruction. So it was mild obstruction, moderate obstruction, and severe obstruction. And if the FEV 1% is less than 70%, a bronchodilator is indicated. So a bronchodilator is given, and then the forced vital capacity is repeated. And when the forced vital capacity is repeated, we're looking for improvement in the FEV1 and the FVC will improve by 200 ml. So remember that's 0.2 on most of the studies that we're looking at, we're looking in liters. So if the FEV1 was 3.2 liters per second before, 3.2 liters, I'm sorry, before the bronchodilator is given, and then it's 3.4 liters, that's 200 ml improvement. And then we look at the FVC, did that improve by 200 mLs? Then yes, the bronchodilator is, or the patient does have reversible airway obstruction. The other value to look at is the FEV 1 should improve by 12%. So that is, you're looking at two different numbers, the FEV1 and the FVC. Two things with the FEV1. The FEV1, if it improves by 200 mLs, that indicates reversible airway obstruction, but also that should show a 12% improvement in the FEV1. So you're looking at two different numbers for FEV1, 200 ml and 12%. For the FVC, it should improve by 200 mLs or 0.2 liters. All right, the next thing on the list is arterial blood gas analysis. So you have to know that the machine calibrates itself. Also, we have to run controls. It's a solution with a known value, and that gets run. And then if the machine doesn't analyze and come up with normal values, then there's something out of range. And we have to troubleshoot what is wrong with the machine. You have to know about standard deviations. So if plus or minus 2 standard deviations is acceptable, an example of that would be like carbon dioxide. It's supposed to be 40 when the control is run, but and it needs to be somewhere plus or minus 2 of 40. So up to 42 or down to 38. So all of that is plus or minus 2 standard deviations. And those are acceptable. But if it's more than that, we have to troubleshoot what's wrong with the machine and why is it not reading correctly. So I wrote, understand standard deviations when running controls. If plus or minus 2 is the standard deviation that is allowed, anything outside that range is not acceptable. And you would have to troubleshoot the machine to find out why it's not giving you plus or minus 2 standard deviations. And typically you start off by rerunning the control. And because it could just be an error in how the control was run. And from there, it could be problems with the solutions, problems with the membrane on the electrodes having to be changed. All right, the next thing on the list of review for the final exam is to set up a green, yellow, and red zone for an asthmatic. So if we'll say the patient's personal best is 8 liters per second, so that becomes 100%. And then to figure out when it drops below 80% of that, So when it drops to 6 liters per second, six liters per second. I don't think I did that right. 8 times 8 is 6.4. All right, so 6.4 liters per second up to 8 liters per second, we're good. But when it's less than 80%, when it goes between 50 and 80%, then the patient needs to, if they're on like long-term, maybe steroids or inhaled steroids or a long-term beta-2 agonist, salmeterol, something like that, and their peak flows are decreasing, then they need to increase their short-term beta-2 agonist, and that should help improve their peak flows. If they're less than 50%, then they should be instructed to go to the ER because they probably need some IV steroids at that point. Okay, next it says predict the flow volume loop for different airway obstructions, such as prolapsed vocal cord, tracheomalacia, and a tumor in the bronchi. So with a prolapsed vocal cord, that's outside the thoracic cage, and inspiration causes everything outside the thoracic cage to kind of collapse during inspiration. So as we breathe in, a prolapsed vocal cord is one it's not functioning, it's just kind of laying there. And it gets in the way. So we breathe in and it kind of sucks in the outside of the thorax and makes inspiration difficult. But on exhalation, it opens up. So on our flow volume loop, we will see a decreased inspiration. Okay, and then for tracheomalacia, if we lose the strength of the cartilage to keep the trachea strong, it's kind of like having that prolapsed vocal cord where breathing in actually collapses the trachea. So the flow volume loop will show decreased flow on inspiration. A tumor in the bronchi. So inside the thoracic cage, when we breathe in, the negative pressure pulls the airways open a bit. And then on exhalation, the airways close a little bit. So during inspiration, air can get past a tumor in the bronchi. But on exhalation, when those airways narrow a little bit, it closes off and makes it more difficult for the air to come out. So the flows on exhalation will be decreased. Okay, next is 6-minute walk test. It says describe what the test is, when it's indicated, how to utilize the Borg scale for determining the patient's feeling of dyspnea. So we know that if they're evaluating a patient having like a lung transplant, if they're reversing, using medications to reverse pulmonary hypertension, if what other sorts of reasons do they do a 6-minute walk test? I guess just to measure a person's strength is how far they can walk. They'll do a 6-minute walk test. So look in your notes for all of the proper indications for the 6-minute walk test. The Borg scale is 1 to 10, with 10 being severe dyspnea. And as far as calculating, let's see what I had about that. So nothing in my notes about it. I know we had to set up the cones like 100 feet apart and have the person walk around it. So look in your notes as far as what is a normal 6-minute walk test for somebody who's not short of breath. Okay, number 9, cardiopulmonary stress test. Know what is measured during the stress test. And we're looking at oxygen being consumed, carbon dioxide being produced, and the anaerobic threshold is determined by looking at those two values. So when carbon dioxide production continues to increase, but oxygen consumption does not, that's the point of anaerobic threshold. And that tells us that the cells are not getting enough oxygen and they're reverting over to anaerobic metabolism. Also, when we're doing a cardiopulmonary stress test, what do we need to monitor on the patient? So we get vital signs, of course, pulse oximetry and 12-lead EKG. When a person is doing a cardiopulmonary stress test, they need some sort of an exercise device that measures the amount of work output. And so that's usually a bicycle or the treadmill. And those are called ergometers because they measure the amount of work that the patient has to do. And the metabolic cart is just something that measures the amount of oxygen being consumed and the amount of CO2 being produced. Indicate when you would stop the test. So if there's ischemic changes occurring in the heart, it's going to cause elevation of the ST segment. Or was it depression? Uh-oh, I don't have my notes with me. I'm thinking depression. Check your notes for that because I don't want to give you the wrong information during the review. If heart rate increases more than 80% of the maximum heart rate for that person, then that would be another reason to stop the test. Okay, and next on the list, or last on the list, is metabolic heart and indirect calorimetry. By measuring oxygen consumed and CO2 produced, the metabolic heart computer can calculate how many calories the patient is consuming. And explain how the test is performed. So we know with metabolic heart, the person has to be breathing a controlled environment. So they can't just be breathing in room air. On a ventilator, it's easy to just add an adapter to the ventilator circuit and measure the air going in and out. If they're not on a ventilator, then a hood can be placed to isolate and control the amount of air being inhaled and the amount being exhaled, so the measurements can occur. And I think it's called the WEIR, W-E-I-R, the WEIR formula for calculating caloric needs. Okay, and then for blood gases, one thing I didn't mention is the name of the CO2 electrode. I think that's a test question when it's talking about the Severing House electrode, so make sure you review that. You need to know the value for normal airway resistance. And I think we went through that when we were going through plethysmography and the body box and what it measures. So 0.6 to 2.4. Airway resistance is what? Centimeters of water per liter per second, pressure over flow. You need to know a normal residual volume compared to total lung capacity. And I think that's it. And that will prepare you quite well for the final exam. All right, I will say goodbye.